Yeah. A great afternoon. Today is a very special day, definitely because I have a very interesting doctor and topic, but we'd like to congratulate the UAE for yesterday's amazing achievement, not only for UAE, but for the entire Arab world. Congratulations on Hope probe reaching Mars. And let's go into our session today. So today we have Dr. Al-Shayma Rizq, specialist endocrinologist in Medcare hospitals. Our topic today is going to be on gestational diabetes during pregnancy. It's different than type 1 and 2, as per my conversation with the doctor before going live. And this is where the doctor will take us through the differences, the symptoms, the treatment, and please, we would love to encourage you to share your questions with us, and the doctor would be more than happy to answer them live. Doctor.
Hello.
How are you today?
I'm okay, thank you.
Good. Doctor, so we are used to hear about diabetes, but today we are going to stress on gestational diabetes during pregnancy.
Yes.
First of all, what is that? What is the symptoms and how can we treat it?
Let's speak about the meaning of gestational of recognition in pregnancy. This includes, or this definition applies, whether the treatment was only medical or only diet, whether this blood glucose intolerance or this abnormality in the blood glucose continues after the pregnancy or stopped just after delivery.
Doctor, first of all, let's go through how does it affect pregnancy?
Yeah, let me tell you that this is a very common condition. It is increasing worldwide dramatically together with the increase of obesity.
Why? What's the reason for that?
Yeah, because it is correlated to obesity. So nowadays, around 7% of pregnancies are complicated with gestational diabetes, which turns out to have 200,000 of females with gestational diabetes annually, which is a dramatic increase.
It is a big number.
Yes, that's why we have a lot of consideration, short-term consideration during the pregnancy and also long-term consideration after the pregnancy. Let's go to the part that you are asking about how does it affect the pregnancy. But how do we diagnose it first? How we know that this female have gestational diabetes? Suppose in the first antenatal visit, the female is assessed for the risk factor for having a high-risk pregnancy and gestational diabetes. Those who are obese, those who have polycystic ovary syndrome, those who has any abnormality in the blood glucose before the pregnancy, those who have positive family history of diabetes, a female who had abnormality in any pregnancy before or any large baby must be assessed. Just starting the pregnancy, you must do a glucose tolerance test. Those who are not in the high risk can do this in 24 to 28 weeks of gestation. But the other ones of high risk must be done just we meet in the first antenatal visit. There are numbers that are confined only to pregnancy. This is called oral glucose tolerance test. We drink a 75 oral glucose, then we see how do our body react to this test. Fasting, 1 hour and 2 hours. Fasting, more than 95. 1 hour, more than 180. 2 hour, more than 155. These are the diagnostic number, which totally differ than the target that we need after the diagnosis. All right? So now this female is diagnosed to have gestational diabetes. What shall we do?
What shall we do, and how can we prepare a patient who got the news that, yes, she is diabetic?
Yes. This female must be told that she must consult a nutritionist. There is a program called MNT, the Medical Nutrition Therapy or the Medical Nutrition Treatments. Together with a nutritionist, we can do a caloric restriction to decrease the blood glucose. So far, this will decrease the fetal outcomes and the maternal problems that happen throughout the pregnancy and even after the delivery. So this program will be given to this female to follow up to reach the target, which is totally different than the number of the diagnosis. There are target numbers to have a fasting less than 90, to have 1 hour less than 140, to have 2 hours less than 120. So far, those female who don't give good results with MNT or the nutrition therapy must go to the medical treatment.
What kind of medical treatment?
Yes.
Especially that she is pregnant, and when we say medical means medicine, and how would that affect the fetus? And
Yes, the only pharmacological therapy that is safe in pregnancy is insulin.
insulin.
Yeah, we must use insulin through the pregnancy to have a controlled blood glucose. And there is another issue that we must follow up. Through whole pregnancy, we must have a controlled blood pressure. So far, we need the medical treatment together with the diet and exercise to have a control goal. And also, not only to reach the goals, we have also to monitor the fetal growth.
Ah.
Sometimes we only add insulin because we have poor outcomes in the fetal growth. So, not only following the patient blood glucose, but also following the fetal growth to change our plan.
Doctor, we went through the pregnancy.
Yes.
But I remember when we were chatting before our session, you mentioned something very, very important, and I think a lot of our audience would not be familiar with it, is doing tests at the early stage of
This
the
is
female.
our message.
Yes.
This is our message for the whole females. Starting from the puberty, I advise most of the females to go to a workup to check out herself. Whether if she have a family history, she must check herself, or will check herself for any abnormalities in the glucose. And must go to a family planning. That's what we want all the females to do. A family planning for pregnancy is safer through the pregnancy and safer through the outcomes of pregnancy and delivery also.
I don't think this is something very common.
It's not common, but it's our new plan.
But it's a very good tip
It's
and a
advice.
message that
It's an advice.
Yes, absolutely.
Yes.
Okay, doctor, what are the warning signs for a pregnant woman who gets the GDM?
The most important warning sign that she have uncontrolled blood glucose. This means that we are not using the suitable dose for her. At that time, that's why we encourage the females to do self-home monitoring for the blood glucose.
How is that done?
This is one simple devices to know her blood glucose, and we write a paper for her for the target numbers. If you don't have the target numbers, she must contact her doctor and follow to change the dose. And this is done not on daily basis, this is done on 1 hour on every meal basis. Yeah, we are always connected with our patients through the pregnancy. All the weeks,
okay.
Yes, we are connected
that's
to
a lot
send
of
us the
pressure,
number
yeah.
to control and the check.
Okay.
And also the females must have been advised, must have been receiving some education to decrease the caloric intake throughout the pregnancy. For example, the females who would have high BMI, above 30. Just after the diagnosis of the gestational diabetes, we must decrease the intake of the calories by 30%.
Okay.
The total reduction of the carbohydrates by 30 to 40% gives good outcome and more glycemic control and better outcomes for the fetus. Because you know the issue, there are short-term and, as I told, long-term considerations.
Yeah.
The short-term are during pregnancy, that the females with gestational diabetes are liable to hypertension disorders and delivery by cesarean section. All right? And this female will have a fetus with abnormalities, sometimes fetal macrosomia, neonatal jaundice, hypoglycemia, hypocalcemia, like this. Moreover, those females for the long term are liable to be converted to type 2 diabetes. Moreover, the long plan that the offsprings are also liable to obesity, diabetes, and metabolic disorders. That's why the plan is not including the female with gestational diabetes. We don't think about those weeks of pregnancy. We monitor the female during the pregnancy, very close monitoring. And then post-delivery, there is a plan. 4 to 12 weeks of delivery, we must monitor the blood glucose. Most probably, the blood glucose and the insulin resistance related to obesity and related even to gestational hormone will decrease. But some females, through the 4 to 12 weeks of delivery, postpartum, they have some abnormalities in the blood glucose. They still have high blood glucose. What shall we do? Those medical treatment they must receive until we reach the target, because we are afraid from the conversion to type 2 diabetes. Besides, she must plan for the next pregnancy.
True.
She must do an effective contraception to go for a healthy next pregnancy. And then she must told that her offsprings must be monitored.
So, doctor, from my understanding to this conversation, would it become a genetic disease?
Actually, it is a combined. Gestational diabetes is a combined genetic disease together with environmental factors. That's why we have some controllable factors, which are the pre-pregnancy weight, the status of the blood glucose before pregnancy, also the family history, besides the personal female history. The personal female history in the previous pregnancies, if she was pregnant before, if she had a large baby, if she had any abnormalities in the pregnancy, if she had any abnormalities in the last pregnancy in the blood glucose. That's why the planned pregnancy is much, much better in the outcomes for those females or for all the females.
Okay. And what is the decent sugar level or sugar blood level during pregnancy?
Yes, for the fasting,
Yeah.
we considered it controlled after the diagnosis of gestational diabetes below 90.
Below 90
Yes.
is a decent level?
Yes, it's good. And for the preprandial, because sometimes we advise our women to measure the blood glucose before the meal. This is called preprandial.
Yeah.
Suppose it is less than 105. Because you know, a persistent high fasting plasma glucose above 105 can cause intrauterine fetal death in the last 4 weeks of pregnancy, which is a disaster.
That is a
It's
disaster.
a shocking. When you know this, we must control the fasting blood glucose. Okay? A persistent high fasting blood glucose causes intrauterine fetal death.
Yeah.
And the presence of gestational diabetes, whatever the severity, causes also abnormalities, as we said before. You got it? That's why the prevention from the start by the planned pregnancy, to have a pregnant with ideal body weight, to have the pregnant lady with a normal blood glucose is better than going to the pregnancy with high blood
Absolutely.
glucose.
Yes.
That's it.
It's a risk. It's a
Yes,
high
it's a
risk,
very high
actually.
risk.
It's a
That's
very
it.
high risk if you do that.
And we said the fasting,
Yes.
this is the decent number.
Yes.
And the 1 hour must be less than 140. The 2 hour after the meal must be less than 120. These are the targets. Together with the growth of the fetus is one of our targets, following the fetal growth through the pregnancy, following the general signs, following the blood pressure of the female, the protein in urine. All of this are the factors that we assess the female.
And doctor, does it end once the delivery is done, or it can continue during breastfeeding and could continue after that?
Yes, for breastfeeding, we advise most of the female with the gestational diabetes to go for breastfeeding. It's very important. Yeah, metabolically, it's good for her. This is number one. Number two, some females after delivery continue to have diabetes. So we will miss them. That's why there is a postpartum follow-up for those females from 4 to 12 weeks after delivery. This female must come, and we will do a test for her to follow up her glucose after delivery. If it is still high, we must give treatment. Enter her in the localization, in the program for the diet, modifying the lifestyle, decrease the body weight, even give her medical treatment to follow up her until she reaches the target normal blood glucose, and do contraception, effective contraception, until she reaches the next pregnancy.
So it's a myth for people who think that if I breastfeed and I have diabetes, that I'll pass it on to my baby.
No, she's passing it by another ways. Only if she is gestational diabetes. This offspring is liable to diabetes. That's why we advise the female to follow up her offspring after delivery.
Okay.
In the adulthood and the childhood, they are liable not only to diabetes.
Absolutely.
They are liable to other diseases such as obesity. Obesity is a disease.
Doctor, can you take us through the insulin treatment?
Yes. Actually, the insulin treatment is given to the female according to her numbers. Some need only one type of treatment with the long-acting treatment, and some need also before the meals another type. It is according to the number of the female. A lot of females, a large number, are giving good results with the diet control.
Yes.
Those who are exercising before the pregnancy can do exercise also during pregnancy. Like 30 minutes of exercise is good, not bad.
Yes.
But she must be fit for this. And she must take the green card from the gynecologist following with her that she can do this exercise.
Yes.
So exercising also together with diet will give good results. Then adding on insulin is according to the numbers. So we never give a strict number to all the females. It is according to her body situation.
Doctor, if we want to give a good tip for ladies who before going into pregnancy. So
Yeah.
you mentioned that the planning is very important, right? What about looking after their weight and looking after their nutrition? So
It's a must. It's a must actually from puberty. The female must be screened from puberty. Starting from puberty to all the women in the childbearing area, in the reproductive age, they must be screened
Yeah.
for any disease of glucose intolerance, for polycystic ovary disease, for hypertension, for lipid profile, even reaching the targets of the body weight. The BMI must be in the normal range and the weight must be in the normal range according to her height.
Okay.
So this is our message to all the females.
So actually, it's a very important message.
To go through them.
Yes.
Planned pregnancy is better 100% than unplanned pregnancy for the outcomes for the fetus and for the mom and for the next even pregnancy.
But does it have to do anything related to age?
For sure.
At what age the woman is getting pregnant?
Increasing the age above 25 gives more risk for gestational diabetes, together with the other risk factors.
And if you are diagnosed with GDM,
Yes.
it can be converted later on into type 1 or 2?
It can be converted to type 2. That's why 4 to 12 weeks after delivery, we will follow this female. But there is a good number of females that increase in weight after delivery and never think about remeasuring again the blood glucose. They are easily converted to type 2 diabetes, which is a long life therapy.
Doctor, again, I'm going to take one step behind a little bit and say and ask about the signs that I should notice that there is something wrong, or I might be, have this GDM.
This starts from the history. Every female must know her history, either her personal history and her family history.
But we don't have this in our culture. It's not too common to know about your history.
It's educational. We must educate.
Exactly.
All the females must be educated to know her family history and to know her own history. She must be educated since puberty to do a pelvic ultrasound to check if she has a polycystic ovary disease or not, to measure the blood glucose, to go to the endocrinologist to see her glucose tolerance test, how it is. Just a female is pregnant, she has to visit the doctor. In the first antenatal visit, in the first visit to the doctor, we put the risk assessment, if she is a high-risk pregnancy or not. The high-risk pregnancy is the history, the weight, the blood glucose, previous pregnancies. Besides the numbers, we give every female a paper to write the numbers. We write the correct numbers and the high numbers. If it is high, so she's in risk. That's why we must follow. Okay. This is common between the patient and the doctor.
Okay, doctor, we talked about the treatment with insulin.
Yes.
What other treatments that the patient can go on during pregnancy?
Diet, exercise, and insulin.
No other medical treatment
that
can be put?
Not advised. It's not advised.
Okay. And is there any side effects from insulin during pregnancy?
No side effects so far.
Yeah.
If the patient is on the good dose, following with the meal or at the timing exactly of the insulin dose.
Okay. Well, I think we have covered most of the questions that we received online here and on Facebook and Instagram. Thank you so much, doctor.
Thank you, dear.
It was really an eye-opener, honestly, to be very honest with you. And and the tips that you said, having the pre-checkup for any woman, even before pregnancy, just to know about her history, about her condition, is very, very important to have a safe pregnancy and continue the 9 months. Yes, absolutely. Yes, we do hope that. So thank you so much. Thank you for your questions. I hope we were able to answer most of them, and to see you in the next session. See you.
Bye.